All right, welcome back to the online causal inference seminar. Today we're excited to have Caleb Miles from Columbia University talk about addressing an extreme positivity violation to distinguish the causal effects of surgery and anesthesia via separable effects. Um, we're looking forward to the talk. As discussants today, we're going to have Thomas Richardson and Jamie Robbins, who prepared a discussion together. Questions today will be handled by Ying. So, Ying, do you want to say a few words?
Yes, thank you, Dominic. So as usual, we will be using the Q&A section to collect questions, and I will be proposing clarification questions from time to time to our speaker. So please do use the Q&A section instead of the chat for us to better track the questions. And without further ado, please feel free to get started.
All right. Okay, slides are okay.
Look great.
Great. All right. Thank you so much to the organizers of the online causal inference seminar. And thank you so much to Jamie and Thomas for agreeing to be discussants again. It's really quite an honor. I think no one's body of work has had a more direct influence on my own than that of Jamie's. And Thomas is maybe not too far behind. Excuse me. So, as mentioned, the title of my talk is Addressing an Extreme Positivity Violation to Distinguish the Causal Effects of Surgery and Anesthesia via Separable Effects. So this is a pretty applied talk. For those of you who are very familiar with separable effects, I imagine a lot of what I'm going to say here is not going to be terribly surprising to you, but for those of you who are less familiar or perhaps even skeptical of separable effects, I'm hoping that this application will help make separable effects a little more accessible and or appealing to you. So this work is in collaboration with my former student, Amy Pitts, who's now at Regeneron Pharmaceuticals, my collaborator, Caleb Ng, who's in the Department of Anesthesiology here at Columbia, and Ling Guo, who was a data analyst in the Department of Anesthesiology, but who's now since moved back to China where she's an MD. And so really worked closely with everyone you see here. They all made substantial contributions to this article. Couldn't have been accomplished without any of them. Okay, so I want to give a little bit of the backstory about how this project came to be. So in 2016, the FDA issued a cautionary statement regarding the potential impact of prolonged or repeated exposure to anesthetic drugs during the third trimester of pregnancy or in children under the age of 3 on their brain development. And this warning was issued after preclinical and clinical studies raised concerns about the safety of general anesthesia on the developing brain, citing potential neurotoxic effects. So while animal studies have been fairly persuasive, human studies have yielded more mixed findings. And so that motivated this study that we conducted that was published last year with my collaborator, Caleb Ng, excuse me, that I was involved in. And the statistics of this study was led by a group at Penn, including Jeffrey Silber, and at least earlier in the study, Paul Rosenbaum was involved. And so, of course, we did a matching analysis. And so we analyzed data from the nationwide Medicaid Analytic extracts, where we matched pregnant mothers undergoing an appendectomy or cholecystectomy to mothers not undergoing any surgery. We focused on appendectomy and cholecystectomy as these are two of the more common and less invasive procedures that are done during pregnancy. And what we found was that compared to children who are not prenatally exposed to anesthesia and surgery, the prenatally exposed children had a significantly increased risk of developing a disruptive or internalizing behavior disorder, or DIBD for short. And what this is a composite of such developmental disorders that consist of ADHD, bipolar disorder, depression, and anxiety, with ADHD being the most prevalent. So this is a rather difficult thing to study for a number of reasons, right? It's an observational study to begin with. But when you stop and think about it for a moment, it becomes clear if you're interested in specifically the effect of anesthesia on DIBD, one of the main limitations is that in this study, we're not able to distinguish the effect of anesthesia from that of surgery, because you're only ever getting anesthesia if you're receiving surgery and vice versa, right? These are observationally equivalent things. And this is pointed out in this comment responding to this article. Part of the title was, "Is it the anesthesia or the surgery?" Where they say, "Inherently, it is never possible to dissociate the exposure of general anesthesia from surgical exposure, as anesthesia is rarely provided in isolation or without a procedural indication." So if we're interested in the causal effect of just one of these exposures on its own, anesthesia, then the other, surgery, is playing the role of a confounder. So ordinarily that would be fine. We just, do a backdoor adjustment for confounders. But here we can't simply adjust for surgery, as we're faced with a clear positivity violation. So for this audience, I don't need to spend too much time on this, but of course, positivity or overlap is a common assumption in causal inference. It's vital for identification of most causal estimands. But this is not exclusive to causal inference, right? This also arises in many other areas, including missing data, survey sampling, supervised learning, and data fusion. So just the definition, if we're interested in the ATE of a binary exposure A, an outcome Y with confounder C, then positivity says that we need the probability of A being 1 within strata of C to be between 0 and 1 for all C in the support of the confounders. But in our case, if C is surgery and A is anesthesia, ignoring other confounders for now, we have A and C are equal. They're observationally equivalent. Hence, these conditional probabilities are identically 0 and 1. So that is, we have really the most extreme form of positivity violation. And of course, this problem isn't resolved when we add more covariates to C. Okay, so there are a number of approaches for dealing with positivity violations. There's extrapolation with an outcome model, quote unquote, moving the goalposts by trimming subjects with poor overlap. We could truncate extreme propensity scores. We could use overlap weights. We could use incremental propensity score interventions, and the list goes on. Unfortunately, none of these approaches are applicable to this extreme positivity violation setting, since these all rely on there being some subset of the population for whom positivity does hold. In our case, there's no such subset. So what can we possibly do here if we're interested in isolating these effects? So in causal inference, hard problems typically require strong assumptions. So this is my caveat, that what I'm going to talk about in this talk is going to involve a lot of strong assumptions, but we're faced with a hard problem. So what else can we do? Okay, so in the 2024 paper, in that analysis, we conducted what's known as a tapered match, which is you could view as kind of a sensitivity analysis that involves doing multiple analyses using nested sets of matching variables. So you may have certain variables that you're not sure whether these should be considered as potential confounders or not. Maybe it's a little bit ambiguous when they happen relative to the exposure, and that's something that was the case in our setting. And so we did this tapered match. We did essentially kind of 3 different matching analyses. And one of these, which we sort of internally referred to as the C match, included certain post-exposure variables. So, for example, complications related to surgery and preterm birth. And I don't think these results even made it into the final paper, but we spent a good bit of time discussing why we were interested in matching on such variables that were clearly post-exposure and how we could interpret results that come from such a matched analysis. And what I sort of gathered from these conversations was the intuition behind the C-match appeared to be to use these variables as a way to kind of get at an effect that is not attributable to surgery. It was thought that maybe these kinds of variables were specifically related to surgery, and if we could match on them, then we could sort of block some of that effect. And after spending some time thinking about this really reminded me of separable effects. And it felt like it was an informal way of trying to get at a similar kind of thing. So I wanted to try to formalize this in the separable effects framework. Okay, so I'll spend a bit of time talking about what are separable effects. So in this seminal 2010 paper, I have to say, I think every time I revisit it, I feel like I learned something new. Robins and Richardson introduced the idea of separable effects, or also sometimes referred to as split treatment, as an alternative way of interpreting mediated effects as so-called manipulable parameters, meaning parameters that one could estimate in a hypothetical, potentially multi-arm randomized experiment. And this stems from the following thought experiment that was introduced by Yuta Pearl that he used to provide a substantive public health motivation for mediation. So suppose the following are observed. A is smoking status, M is hypertensive status, and Y is myocardial infarction. And so suppose you have this simple mediation DAG. Pearl imagines that a procedure is developed in the future to remove nicotine from cigarettes, and further supposes that the entire effect of nicotine on MI is through its effect on hypertension, the M, and the effect of the remaining components of smoking have no effect on hypertension. He then argues that this causal parameter here that is the sort of important ingredient in like the natural direct and indirect effect, this mean of a cross-world counterfactual, can then be interpreted as the risk of MI if one were assigned to smoke nicotine-free cigarettes. Further, he argues that this parameter is identified under his nonparametric structural equation model, or NPSEM, which involves so-called cross-world counterfactual independence assumptions. So Robins and Richardson consider an extended version of the DAG used by Pearl that captures these additional elements in his story. Namely, the extended graph captures the nicotine N component, the other non-nicotine components, O, of cigarettes, as well as their deterministic relationship to A, indicated by these red arrows here, and their relationships to M and Y, namely the other non-nicotine components don't affect hypertension, and the nicotine components don't directly affect MI with respect to hypertension. So they show that under this extended graph, both the mediation parameter and this other parameter that is the mean of the counterfactual under a joint intervention, setting the nicotine components to 0 and the other non-nicotine components being 1, being present, are both identified by the G formula under their minimal counterfactual model, which is free of cross-world assumptions. And therefore, these are both manipulable, again, meaning they could hypothetically be estimated by, in this case, randomly assigning individuals to smoke nicotine-free cigarettes. Importantly, this identification is shown to hold in spite of the fact that O being 1 and N being 0 are never observed in the same person, since in the hypothetical observed data, O, N, and A are always equal to one another. And this framework has since been used for addressing a number of things, such as spillover effects, mediation and survival analysis in longitudinal settings, intercurrent events, and noncompliance. Okay, so back to our anesthesia problem. So now I'm going to introduce notation in our setting. Okay, so we'll let A be an indicator of the decision to undergo appendectomy or cholecystectomy. A sub A is an indicator of receiving anesthesia, and A sub S is an indicator of receiving surgery. And so in our case, these are all going to be observationally equivalent. If you decide to undergo appendectomy or cholecystectomy, then you're going to receive both surgery and anesthesia. Y, our outcome, is time to developmental outcome, as measured by this DIBD composite endpoint. And C consists of a host of baseline covariates. We just used the same set of covariates that we matched on in the previous paper. In that paper, we spent months going back and forth discussing which variables we want to match on. And so these are just kind of umbrella categories. In the supplementary materials of the paper, you can see a full table. Okay, and so what is our causal estimand? So we're interested in the following effect decomposition. So on the left here, we have the joint effect on the relative risk scale of both surgery and anesthesia on risk of developing DIBD by time t. All right, and so this is what we were kind of able to at least try to get at in the previous paper. But by multiplying and dividing by this probability of Y under the joint intervention setting surgery to 0 and anesthesia to 1, we can decompose this into an effect specifically of surgery, an effect of anesthesia. And so there are a few things to discuss about these parameters. The first is, well, what are the sort of medical policy implications of these various parameters? Well, if you're interested in specifically deciding whether to delay surgery until after pregnancy, then the relevant parameter is going to be this joint effect here, right? Because we're not actually thinking about assigning anesthesia without surgery or vice versa. And that's also not to say that this is the only thing that should be taken into consideration if one were to be making such decisions, right? The higher priority is the management of the appendicitis or cholecystitis. At the time of the data that we have from Medicaid, basically anytime a mother had appendicitis or cholecystitis, they would receive surgery. In more recent years, at least acute appendicitis has begun to be treated with antibiotics. And so there is an alternative where one could delay. Okay. But my colleague, the anesthesiologist, is specifically interested in the effect of anesthesia independently from that of surgery. And so what is the sort of medical practice relevance of that? Well, it's certainly not whether or not we should be administering anesthesia when they're getting surgery, of course. But if we're able to isolate, we see that there is a harmful effect of anesthesia, then that might inform how we administer anesthesia in terms of the anesthetic agents or the duration of the exposure to anesthesia. Whereas if we see there's no harmful effect of anesthesia, then we don't need to worry about that. We can maybe focus more on potential harmful effects of surgery. The other thing I want to mention is that here are effective anesthesia specifically in the absence of surgery. We could have decomposed this a different way where this was instead in the presence of surgery. But there are a couple of reasons why we're not interested in that, or well, really one reason why we're not interested in that, and that is the effective anesthesia has a potentially harmful effect that we are interested in. And then it has another intended effect that we're not so interested in, and that's the suppression of pain. And so if we were to ask about the effect of anesthesia in the presence of surgery, that would involve some additional, likely beneficial effect that is a result of avoiding a stressful or traumatic response to pain that one would experience while undergoing surgery. The other reason is that, in fact, as I'll discuss later, the alternative estimand is in fact not identified in our setting. Okay, so I'm wondering if this might be a good place to stop and see if there are any questions.
Thank you, Caleb. At this point, we don't have active questions, but we encourage
Okay.
the audience to submit them
Sure.
once you have them. Yeah, thank you.
Thank you. Excuse me. Okay, so adapting the separable effects model or framework to our problem, then if this DAG here holds, then that means that we can identify all of the causal estimands on the previous slide. And so here, this looks a lot like what we saw before. Now we have, right, A is split into anesthesia and surgery. And so what this DAG is saying is that if there exists a set of variables M, that completely mediates the effect of surgery on the IBD and that is not itself affected by anesthesia, and if there are no unmeasured confounders of the effect of M on Y, then that means that if we observe these variables M, then we can identify these causal estimands. And in fact, their identification formulas are the same as those that are used for the natural direct and indirect effect decomposition. So that means we can also use estimation tools from the mediation literature. And what I think is kind of interesting about this application is to me, this seems like a bit of an inverted perspective on separable effects. So under the separable effects framework, one often begins with an exposure A of interest and some intermediate variable M that's also of interest, either because one is interested in mechanism with respect to M, or it's some unavoidable nuisance, maybe censoring by death. And one often then also comes up with a story about components of A that you could split A into that would justify this extended DAG or some other type of extended DAG. Whereas in our case, we start with the separate components of A, anesthesia and surgery, being explicitly the exposures of interest, and the estimand is not really in terms of mechanism or makes no reference to some variable M, and instead we want to come up with some story about a set of variables M that would justify the extended DAG. So the M is really only playing kind of a identification role. And so we want to come up with a set of variables that completely mediates the effect of surgery and that is also unaffected by anesthesia. And so these are sometimes referred to as full isolation conditions. Okay, so I spent quite a bit of time discussing with my collaborator what such variables, what set of such variables might exist that could potentially justify such a DAG. And we came up with the following list. Excuse me, that were observed in the Medicaid data. So we have perioperative complications related to surgery, need for reoperation within 30 days, a measure of pain, perioperative length of stay, cesarean delivery, preterm birth and low birth weight, thromboembolism, and ER visits unrelated to prenatal care. So these are all variables that were in fact measured, available in the Medicaid data. A couple of additional ones that were not measured, but might also play a mediating role of surgery are inflammation induced by the surgery and maternal acetaminophen use. We are hoping that some of these perioperative variables here are at least helping us capture such inflammation. But if not, and if these are in fact playing a role, then we will also need to do some sensitivity analysis. Okay, so under our DAG, our causal estimand for any values that we want to set AS or AAA to is going to be identified for each combination A star and A and 0, 1, with an exception I'll talk about later, by this formula here you see on the right-hand side. And this is just the mediation formula specifically for if we have a survival outcome. Excuse me. And then from this, we identify our estimands of interest, our joint effect, effective anesthesia, and effective surgery just by taking ratios of these. So as I mentioned, given how strong the exclusion restriction assumptions are, it's essential to perform analyses to assess sensitivity to their violation. So in particular, I'll focus on this exclusion restriction violation, this direct effective surgery with respect to M, as we feel that the exclusion restriction, that anesthesia is unlikely to have an effect on any of these M variables, but we're less certain about the effective surgery on Y. And so we develop an approach related to that proposed in this Stenser et al. Paper, but we have a sensitivity parameter that's scalar and causally interpretable. So I'll talk about that parameter when we get to the data analysis. But one other thing to mention is that under violation of this exclusion restriction, this is referred to as partial isolation. So in our case, A sub A, partial isolation. Our identifying formula still does identify some causal quantity, at least if we're willing to imagine that we can intervene on M, or that we can interpret interventions on M. That looks like a direct, a version of a controlled direct effect of A on Y with respect to M, where we're marginalizing M over the distribution of the counterfactual M under A being 0 and C. So there is a kind of direct effect interpretation of our estimate, even if this is violated. But it's not, of course, not giving us specifically the effective anesthesia in the absence of surgery. Okay, so I want to spend a little bit of time trying to provide some intuition behind why this separable effects works, even though we have this extreme positivity violation. Maybe this feels a bit like magic, like we're sort of cheating or getting away with something. So I want to provide a little bit of intuition. So the high-level intuition, I think, is just that if we're interested in the effect of AA and not that of AS, then we can sort of use M to block the effect of AS so that we're left with just the effect of AA. So that's pretty high level. In the Robins and Richardson paper, the identification result just follows directly from the G formula, but it might not be that clear why certain positivity conditions are not required for the G formula to work. And so, in any case, so I want to connect this to backdoor adjustment, something that's very familiar and hopefully elucidates kind of why we don't need to worry about this positivity violation. So based on this DAG here, the A sub S or sorry, if we're interested in the effect of A sub A on Y, then the A sub S or just A satisfies the backdoor criterion. So ordinarily we would, simply just adjust for one of these variables and we would be done. But of course, because positivity is violated with respect to A sub S, we can't do that. But clearly here, M also satisfies the backdoor criterion. So this gives us an alternative sufficient adjustments set. And so as long as positivity holds with respect to M, we can identify this guy just by backdoor adjustment using M, right? Okay. Now, this same parameter here can be shown to decompose into this expression on the right here, right, which just involves probability of A sub S, which we observe A, so we know that prevalence. And this guy here with A sub A set to 1 and A sub S set to 1, well, this is just the mean of the counterfactual with A being 1, which in this DAG is simply identified by the mean of Y among the exposed. And so all that's left is this term in red here, this like mixed joint intervention, which is the thing that we want to identify. But all the other terms in this expression are identified. So we can simply solve this guy in terms of all the other things that are identified by backdoor adjustment. So this all just follows from backdoor adjustment. And one can show that the same thing, you could make an analogous connection to front door adjustment by instead focusing on A sub S and thinking about adjusting A sub A, but then use front door with respect to M. Okay. Now, since this works for the most extreme form of a positivity violation, this suggests that the same idea could be used for less extreme violations. So suppose that you have a set of confounders that you could partition into a set, say C plus and C0, and that within a certain stratum of C plus, you still have variation in A, but within that stratum, say little c plus, A is determined by the remaining confounders, say C0. So if we have an ordinary kind of positivity violation, by conditioning enough on variables, we can reduce it to a sort of extreme version of a positivity violation, such as in our setting. So then there will be an extreme positivity violation. So probability of A being 1 will be identically 0 or 1 for all C0. If we can, if we can come up with a set of variables M that justify this DAG below, then we can use these to identify the mean counterfactual Y of A within this stratum. And then for values of C plus where positivity holds, we could just use standard backdoor adjustment. So this gives us a way of kind of using this separable effects idea from extreme positivity violations and porting it into more ordinary positivity violations. Okay, so one slide on estimation. So recall that our causal parameter psi A star A is identified by this like mediation formula guy here. So how did we actually estimate this? Well, we estimated survival curves 1 minus psi hat for each counterfactual using a mediation estimation approach with proportional hazards model adapted from this 2011 Vanderweel paper. Basically, fit a proportional hazards model for the outcome, plug in the estimates here, and then marginalize over the distribution of M, conditioning on A being little a star, and then averaging over C. Now there's a bit of a wrinkle here. Modeling the mediator distribution does require some care because many elements of M only occur among the exposed mothers. By that I mean exposed to surgery and anesthesia. because some of these mediators were sort of surgery specific. So for such variables, we only modeled these probabilities on the exposed mothers because we knew that their probabilities were 0 among the unexposed mothers. Excuse me. So in fact, due to this additional kind of form of positivity violation, that is the probability that some of these mediators being 1 is 0 among the unexposed, it turns out that we can't identify the other term, that is surgery in the absence of anesthesia. So that was involved in that other form of decomposition that we were less interested in to begin with. Okay, so now let's talk about the data analysis, unless there are questions. I don't know if now is a good time.
Hi, Caleb. Thank you for asking. We do have some questions. The first question is, have you considered organic direct and indirect effects?
Yeah, I'm not as clear how those would factor in here. So because we are specifically interested in this like split treatment, right? And as far as I'm aware, the organic direct and indirect effects are kind of preserving that initial exposure, but aren't really splitting it into. So I'm not sure I see a direct connection here, although perhaps there is some. But really, we're interested in these deterministically related exposures that I've really mainly only seen show up in separable effects.
Sounds good. Thank you so much. Another question we have is there any possible endogeneity problem here and how to address it?
Yeah, there's certainly I'm going to talk about later. There's a particular endogeneity problem that I've been sweeping under the rug that may be a major issue, that is basically another kind of potential confounding by indication by the underlying inflammation itself, that's requiring surgery, the appendicitis or cholecystitis, right? And as I mentioned, really during the time period where we have data, the mothers who have either of these are getting the surgery. So this is actually induces yet another extreme positivity violation. So far we've just been assuming that there's no direct effect of the underlying inflammation on the outcome, that it's all through the surgery and anesthesia. So I'll talk about how one might be able to account for that with more recent data later on in the talk.
Thank you so much. That's all the questions we
Okay,
have.
great. Thank you. Okay. All right, so for the data analysis, we analyzed this data from the nationwide Medicaid Analytic extract from 1999 to 2013, linking deliveries to mothers enrolled in Medicaid during pregnancy. Excuse me. So about 31,500 children were exposed to general anesthesia from maternal appendectomy or cholecystectomy, and about 14.3 million unexposed children not exposed to either. So the time window of baseline covariates for exposed mothers was defined as all records up to the date of their surgical procedure. Now, due to the unexposed group not having such a procedure date because they didn't receive surgery, for each unexposed mother, we created a pseudo operation time to ensure that there was a similar distribution of covariate observation windows to that of mothers in the exposed group. So we did this by basically kind of sampling from the distribution of actual operation times to ensure that they have this similar distribution. So a little bit ad hoc solution to a bit of a thorny problem, but it kind of mirrors what was happening when we were matching in the matching analysis. Okay, so here are some results. So here are estimated survival curves for counterfactual DIBD outcomes, where S00 is the survival under no surgery or anesthesia, S11 is under both surgery and anesthesia, and S01 is under anesthesia but no surgery. So those are this like pinkish red line, the blue line, and the green line, respectively. So this is survival up to 14 years of age. Recall this is a diagnosis, so it takes some time before children start receiving such diagnoses. But we're seeing this joint effect of surgery anesthesia is this gap between the pink and blue curve here. So we see that there is an apparent effect, joint effect of surgery and anesthesia, at least if we're willing to believe, we're adequately controlling for confounding. And we're seeing that this green curve, anesthesia but no surgery, stays quite close to the blue curve, which is both surgery and anesthesia. So this suggests that the effect is not explained much by surgery, but rather by the effect of anesthesia, which is captured in this gap between the pink and green curves here. Again, at least if we're willing to believe that all of our assumptions hold and are right in the separable effects model. Okay, and so our estimated effects on risk of DIBD diagnosis in children, specifically at age 10, with corresponding 95% confidence intervals are shown here. So we're seeing, indeed, there's a statistically significant joint effect, harmful effect, and that much of that seems to be attributable to anesthesia rather than surgery, though surgery is also statistically significant. Now, of course, again, the usual caveat, nevertheless, these findings could well be biased due to a violation of our exclusion restriction assumptions. So, so we performed a sensitivity analysis specifically to the no direct effect of surgery on DIBD with respect to M. And we see that, so we have a sensitivity parameter adjusted version of the effective anesthesia estimates at time 10, at year 10, where on this x-axis we have this sensitivity parameter gamma, which is this thing here, which looks like what we saw before, which was kind of looks like a controlled direct effect of the exposure with respect to M marginalized over the distribution of the counterfactual M with A set to 0. But here, in this contrast, anesthesia is fixed at 1 and surgery is varying from 0 to 1. Whereas before it was the joint effect. So this is like the joint, this is essentially a kind of controlled direct effect of surgery with respect to M when anesthesia is present. Okay. And so we can see that this, at 1, we just have no adjustment. So that's our point estimate in 95% confidence interval. And by increasing this sensitivity parameter, we can see how large this direct effect of surgery would need to be in order to make this no longer statistically significant or a null estimate or reverse the direction of the conclusion. And so we see that this comes out to be right about 1.13 or so. So I would say moderately sensitive to such direct effects, but this effect is larger than that of the effect that we're already seeing through M. So any direct effect would need to be stronger than the cumulative effect through all of the M's that we observe. Okay, so we also stratified the...
Sorry to interrupt. I just
Oh,
want to
yeah.
remind you of the time. So it
Oh,
would be
okay.
great to if
Yeah,
you finish in 3 or 4 minutes. Thanks.
sure, sure. I'll go over this super briefly. As a sort of an additional sensitivity analysis, we stratified into just appendectomy versus no surgery and just cholecystectomy versus no surgery, and we found that their effects were quite similar. So limitations of the study, we're obviously relying on very strong assumptions in our DAG, and there's quite a lot of censoring, and it may be informative. Censoring is mostly due to people disenrolling from Medicaid. This is not something we really accounted for. We're using fairly simple statistical models and assuming proportional hazards. And the last one that I'm going to spend a bit more time talking about is we have not accounted for confounding by indication. So we could alternatively ask, is it the anesthesia or is it the underlying inflammation? So as I alluded to before, if I is an indicator of the underlying inflammation, then we also have right in the data that we currently have, that's observationally equivalent to whether they had the surgery. And we've just been assuming this direct effect is not present this whole time. But more recently, acute appendicitis has begun to be treated with antibiotics. So with more recent data, one thing we could do is restrict, we could let I sub app be an indicator of whether the patient had appendicitis specifically and restrict to only mothers with appendicitis. And then let A star be an indicator of whether they are treated by surgery / anesthesia versus if they are treated with antibiotics. So in this case, with this more recent data, then we would have variation in surgery and anesthesia within appendicitis, and we could identify the joint effect of surgery and anesthesia, even if there's a direct effect of appendicitis, because we would actually be able to control for that. Furthermore, with the right variables M, we could use this approach that we've been talking about in this talk to identify separately the effects of anesthesia in the absence of surgery, even if there is this direct effect here by leveraging these variables here. Okay, so final discussion. We've moved, I'd argue, in the direction at least of better understanding the effect of anesthesia separately from that of surgery. This emphasizes a perspective on separable effects in which we explicitly start with the separate components that are of substantive interest and not the M variables, and then identify these mediating variables that justify our DAG. Under strong assumptions, we can overcome the most extreme of positivity violations, suggesting that this approach could potentially be extended to overcome milder positivity violations. And then lastly, this approach can be applied to similar cases. Excuse me, for example, if the exposure is a package intervention and we're interested in understanding the effects of individual elements of such interventions. So thank you very much. This paper is on arXiv. Here's a QR code here, and please reach out to me if you have questions or want to discuss. But thank you.
Thank you. Thanks for the great talk. I think in the interest, there is one open question, but maybe we'll move that to the end, and just in the interest of time, let's move over to the discussion. So Thomas and Jamie, whenever you're ready.
Okay, can you see my slides?
Yep.
Okay, so this is going to be a joint discussion. I'll go as far as I can until Jamie disagrees, at which point he'll jump in. So I want to thank the organizers for letting me do this discussion. As we were preparing the slides for this, I realized that almost 1 month more than 2 years ago, we did a discussion of a previous paper by Caleb in OSIS that was also on mediation. And that paper was little easier for us to prepare the discussion of, because essentially Caleb had a very nice criteria for a test for a criteria that mediation analyses should satisfy, but he didn't say a lot about separable effects. So our discussion mainly consisted of saying, Caleb, you should say more about separable effects. But now, 2 years later, this talk was a little more difficult to discuss because Caleb is talking about separable effects a lot. So just to so some of this will be review of the things that that Caleb just presented, and partly maybe I'm just connecting the notation and the way of describing it to the context that we looked at before, and we want to make a point that there are other approaches. Tyler Vanderveel has an approach that he refers to as interventional mediation, but in a certain sense, we think this is actually interventional mediation, whereas because it's directly relating to these interventions on split treatments. And I should also say some of the things I'm presenting here are also joint with Ilya Spitzer. So the classic example that I think Caleb referred to that was originally presented by Pearl as motivation was this idea of a smoking cessation trial. And here, part of the main thing I'm doing here is that Caleb was referring to anesthesia and surgery, and I'm going to use this notation as a way of sort of allowing us to think about both Caleb's graphs and the graphs that we've discussed. So essentially, we have a treatment, a mediator, and an outcome, and then we're going to split treatment into these two components, one between the treatment and the mediator, and one between the treatment and the outcome. And we called them N and O for nicotine and other, but in Caleb's context, it's surgery and anesthesia. And the basic idea that Caleb already alluded to is that by splitting the treatment into these two components, it allows us to distinguish a direct effect and an indirect effect, where essentially we imagine a hypothetical trial where even though in our observed data everyone either got x equals 0 or x equals 1, we think about a hypothetical experiment where people get one component and not the other, and this allows us to come up with a notion of a direct effect or an indirect effect. So that's the basic idea. So as Caleb alluded to, you end up with this the mediation formula, but the mediation formula in the context of this expanded graph can be thought of as a G formula. So essentially, the identifying formula of the original data over x, m, and y takes this particular simple form, which is just the same thing as Pearl's mediation formula. But you have this concern, which is that if you think about it in terms of the original data, this is now a G formula where the values that we're conditioning on with respect to x are different. That's sort of the whole point about why the mediation formula was new and novel. But then this raises this question about how can we think about that? The fact that you have some nagging concern that Caleb also alluded to, which is, well, there was nobody in the original data who had, say, NS equals 0 and OA equals 1. What is going on? How is it possible for us to actually identify the effect here? And I should say here, in the original 2010, the Shrout paper where we first discussed this, Jamie and I had a lot of discussion about this because it wasn't clear how these, it seemed as if the argument relied on conditional distributions that weren't identified from the original observed data, and that indeed is the case. And I should say that the key point is that we're importing assumptions from a world where we're importing counterfactual independence assumptions from a world where somebody ran this 4-arm trial where they randomized, where they did assign people to different values of N and O. And I'm going to say a few more remarks about that, but the key thing is, in a certain sense, this argument I think has been clarified, and the assumptions are now in some ways, a lot cleaner than they were in that original the original presentation in 2010. So a way to think about this, simple way to think about this, is you just imagine three different data sets. So the original data set is the one that we have over X, M, and Y, and we'll suppose that X is randomized, so that we get to see the intervention distribution on the joint of M and Y, the mediator and the outcome. But then we imagine what we would like to have done, which is run a 4-arm study where we randomize these two components. And so we have 4 different arms corresponding to 4 combinations of N and O. We didn't run that trial. And then the third data set we imagine is one where somebody did run that 4-arm trial, but for reasons unknown to us, they deleted the 2 arms where N and O, the values of N and O were different, and they only retained the 2 arms where N and O took the same values. And so the idea is that, well, because in the original data, everyone that got X equals 1 got both N equals 1 and O equals 1, and everyone that got X equals 0 got both N equals 0 and O equals 0. The two arms that were retained in data set 3 are the 2 arms that we observed in the original data set. So essentially, the data set from 1 identifies these 2 arms where N and O take the same value. And then the question is, what additional assumptions are necessary to get beyond what Caleb was referring to as this extreme positivity violation? What additional assumptions would let us reconstruct those other two arms, the arms where N and O took different values, from the data that we've observed? So how could we use the data on the mediator to allow us to reconstruct what we would have observed if we ran this 4-arm trial and we looked at the arms where N and O took different values? And I'll present some assumptions. And I should say some. The assumption that I'm making in relating 1 and 3, there is a sort of consistency assumption going on here, and Stensrud has pointed out, Matt Stensrud has pointed out, that could be tested in a 6-arm trial. Anyway, so the question we're interested in is when are those 2 extra arms where N and O are different identified from the data in 1? And essentially the assumptions are described by this SWIG. The assumptions are that we require that the conditional in the world where we ran the 4-arm trial, we require that the conditional distribution for Y given M does not depend on the value of N, and in addition, the marginal distribution of M does not depend on O. So these are these assumptions corresponding to these missing edges. Okay, and so a key point, and something I actually wanted to say as a point of discussion with Caleb's. So Caleb presented one sensitivity parameter, but there is something, in a certain sense, it seems to me that potentially there should be more than one sensitivity parameter here, and maybe that's just that the other ones were less important to worry about. But in particular, confounding between M and Y would violate, if there were a confound between M and Y, then we would then get that the conditional distribution of Y given M would depend on N in the world where we ran the 4-arm study. The assumptions that we're making here are assumptions that in principle could be tested if you were to run this 4-arm study. There's an issue, obviously, that I don't know, that would seem highly unethical in the setting that Caleb's describing. But at least conceptually, even if it would be unethical, we understand what are the assumptions that are being made. So Caleb formulated the argument in a slightly different way, which was very interesting. Jamie and I were discussing that a lot in looking over the slides, that essentially Caleb considered the backdoor formula in the context of this this model, where we just intervened on O and then finally went to this model to then get identify the situation where N and O took 2 different values. so from my perspective, the identification of this guy was via the back door, was using this assumption, and then in the decomposition that was on slide 25 that Caleb had, he used an independence that was essentially this. And the point that I just want to make is it's very important that these counterfactual independence assumptions must hold in the forearm world. So these are not assumptions that restrict the observed distribution, because they relate to the setting where N and O are taking different values. And so yeah, it's there's a sort of faulty logic. Somebody could say, oh well, actually, supposing that those extra edges are present, suppose that those direct effects that are assumed absent in Caleb's argument, suppose that they were there. Well, look, I can see that, why couldn't I do backdoor adjustment using M and NS? Because because you might think that owing to determinism, that the argument would still go through, and that reasoning would be fallacious, because the assumptions that are necessary are assumptions that relate to the counterfactual distribution in the world where we did run the forearms study. So the proof that these things that the identification results follow from these two assumptions that I've got here is pretty simple. It's sort of basically 2 lines. I won't try to go through it here, because I think unless people want to see the details, because I think I'm running out of time. And the last comment I'd say is that this approach also gives a way to think about a problem that has been discussed a great deal in mediation, which is the problem where what happens if I have something that is comes after the first treatment, but is a confounder of the mediator and the outcome. And essentially, this approach, we can sort of distinguish 3 different circumstances. The first 2 are circumstances where one component of treatment affects this post-treatment confounder. And in these 2 cases, we have identifying formulae. And then the third is the one where if both components affect this, then we no longer have identification for the separable effects. So these are the identifying formulae in these 2 cases, and in the case where N and O both affect L, then we get stuck, basically, because you'd need to sort of have something that looked like this, which obviously is not possible. And so I think I'll just say there's been other work relating to, Caleb already referred to a lot of work that's extended this on separable effects, and this already came up in the question and answer that Judith Locke has a related approach involving organic mediation. And I think I will stop there. Thank you, Caleb, for inviting me to give a discussion. I don't know, maybe if I have 1 minute, 2 minutes left, I'll let Jamie add anything that he thought I missed in the discussion.
Sure. Well, thanks for the discussion. Jamie, do you want to add something?
Yeah, can you hear me?
Yes.
Hold on. Can you still hear me?
Yes.
Yes.
Okay. Thomas, if you let's see, there are a couple things. If you go to the last slides with the 3, with the L's, yeah. So one thing is, notice that actually slide A has, so remember L's measured here. So slide A is actually can be rethought of as what Caleb already did. So because you can just call M a new M star. That's his M. It's just that both M and L together, because you'll see it looks just like there's no reason you can't have just those are that, and that gives it his complete. Then you have the only way to get through from NS to Y is through M and L, which is just his. That's what he called M.
Just because these 2 factors could be put together, basically.
Yeah, if you can read them. Okay. And then, but B is more interesting because that's a new, that's if that's the state of the world. Think of A and B as two possible states of the world. If that is the state of the world, and you think that's the state of the world, you could still identify, um, you know, when N and O take different values, but it's not the ordinary G formula. It's a different formula. And so that's interesting from Caleb's story, because being also a doctor, I'll give you a story where you would it's contrived but is medical, where you would have graph B, which is there's for certain anesthetics, they cause when you get them in surgery, they cause malignant hypertension. And so um, if so L could be malignant hypertension. So notice in B, it's caused by the anesthetic, which is true. And it can just cause horrible damage to the fetus and your subsequent health care. So it will cause both M, which was things like, do you have to stay in the hospital 7 days? And it will cause Y because you could get hypoxic. The child could get hypoxic during this. So I just gave you a reasonable medical description of exactly this problem where the identifying formula is actually B, which isn't the G formula. But it depends what you think the state of nature is. If you think the state of nature that L causes that that like OA causes L, the cross things that what am I saying? Yeah, if you have NS going to L as well as OA going to L, as Thomas said, nothing's identified. That was my main point.
Thanks.
Great, thank you. Caleb, we are really running out of time, but Caleb, do you want to just very quickly respond?
Yeah. I'll try to be quick. Yeah, thank you again, Jamie and Thomas, for the really nice discussion. I'm going to ask for you to share your slides. Yeah, in fact, we did talk about both of these. I think we moved to a different slide, but both of these possibilities where you have such an L, and Jamie, you're absolutely right. This is kind of the exercise we were performing, is like, oh, well, if we have a candidate set of M, if there is some additional L that is plays the role in panel A, then we'll just lump it in with the rest of M, and then it reduces back to the right mediation formula. We also discuss panel B in our supplementary materials, but really for completeness, not because we had an idea for such an L, but that's a very interesting example to consider that Jamie gave. We did not really talk about sensitivity analysis for a confounder of the effect of M on Y. I think we were just thinking more about the exclusion restrictions, but also we matched on a pretty rich set of covariates. Hopefully, if that's sufficient to control for the effect of the exposure on the outcome, it will also be sufficient to adjust for confounding of the effect of the M variables on Y, although of course that's not guaranteed. We're not even sure it holds for A. But I think that would you be able to just apply existing sensitivity analyses from the mediation literature for unmeasured confounders of the effect of M on Y? I would think so. I would think that you would need to develop something new. I think there was some mention of, the other, and there's also a question about a lot of these recent developments extending to survival models and longitudinal outcomes, and did we consider how those might play a role in our setting since we have a survival outcome? I think that in our case, the set of mediators that we consider are all either perioperative or perinatal, which is prior to like, time zero of the outcome. So there's not a kind of temporal, there's not a, concurrent temporal exchange between mediator and outcome where we need to consider the mediator sort of longitudinally. It's sort of cleanly exposure mediators outcome. Now, maybe we could do something to try to deal with the loss to follow-up in a time-varying nature, but that's things were complicated enough, so we didn't really think about what variables. I think also disenrollment for Medicaid is pretty complex, and it's hard to think about how to split treatments in a way that would inform those. So I don't know if I think I'll stop there. I don't know if there are any like outstanding questions I missed. Thomas, would you have something to
Yeah,
say?
I just had one really brief thing, which I wanted to say. I forgot to say. I thought this point that Caleb made early on about thinking about the components and first, having the components first, and then thinking about coming up with finding mediators that would block the pathway for the component that you're not interested in or that you're less interested in. I thought that was a very interesting methodological way of framing the problem, which is different from the way that people usually think about it. So I just wanted to highlight that.
Okay, go ahead. Stop it.
Oh yeah, we're really running out of time.
Sure. Thank you.
Sorry about that. Yeah, first, thank you so much, Caleb, for a very interesting talk, and Thomas and Jamie for an insightful discussion. Yeah, thank you all for coming. I just want to say, like, next week we're going to have a Thanksgiving break, so we're not going to have a seminar the week after. We're going to have Rachin Shah from the University of Cambridge, who will talk about Hunt and test for assessing the fit of semi-parametric regression model. Thank you all for coming. I hope you have a great week, great Thanksgiving week, and see you all after that.